welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Now we have Brandy Hernandez, who is a PGY2 EM resident at Mayo Clinic in Rochester. She will be presenting a journal club on Droperidol for abdominal pain in the emergency department for morphine equivalent reduction, the DREAMER study. Thank you.
Thank you for the introduction, Dane, and good afternoon, everyone. As Dane had mentioned, I'm Brandy Hernandez, the PGY2 Emergency Medicine Pharmacy resident here at Mayo Clinic in Rochester, Minnesota, and I'm very excited to present with you all today the DREAMER study looking at Droperidol for abdominal pain in the emergency department for morphine equivalent reduction. Getting into the background of the study and essentially why it is important, it's important in that abdominal pain has a high prevalence in the ED, leading to one of the most common ED chief complaints in the U.S., compromising around 7 to 9% of annual visits from the years of 2009 to 2018. So given its prevalence, managing pain effectively while minimizing opioid use is a key challenge in our ED setting. And we know that opioid utilization comes with risks, essentially that they may lead to prolonged use, dependence, and even higher rates of nausea and vomiting, in which we're trying to avoid specific to this disease state. Now, as far as any sort of guidance that we had or have to go ahead and look at evidence-based practices to implement into the emergency department, one that we have and I feel like was best attributed to this study is our GRACE 2 guideline recommendations. So essentially looking at best recommendations for its use or treatment in the emergency department. But there's specific caveats with this in which they essentially define this sort of abdominal pain by these 3 criteria depicted on the slide. So really they use these guidelines to treat recurrent abdominal pain, which is defined as essentially 2 episodes of abdominal pain happening greater than or equal to 30 days apart, but within a 12-month period. They also look at undifferentiated abdominal pain, so essentially looking at there being no clear etiology identified following previous workup, including a CT abdomen and pelvis as well as labs. And then they also deem these more so as low risk, so essentially having the absence of hemodynamic instability, irritable bowel syndrome, previous bowel obstruction, active cancer, and solid organ transplantation. So if we have a patient essentially meeting all of these criteria, we are then essentially wanting to look at pain control from a multimodal approach that is opioid minimizing as well. Now, as far as previous literature, there's one study in 2021 called the SHAPE trial that essentially looked at haloperidol with abdominal pain and looked at essentially what are the outcomes related to that. So essentially, the diagnosis that they most commonly looked at were cyclic vomiting syndrome, colitis, diverticulitis, gastroparesis, pancreatitis, GERD, and unspecified abdominal pain, to name a few. And as previously mentioned as well, the first-generation antipsychotic that they specifically looked at was haloperidol. And their summary and recommendations going forward from the study, or the conclusion is that when haloperidol is combined with ketorolac, we saw a reduction in opioid use and rescue therapy compared to just opioids alone. Which now takes us to the DREAMER study, which is very exciting, in which in the SHAPE trial, we did see that reduction in opioid use. So now we essentially want to understand, is this more so of a class effect, and see if it has that reduction as well whenever we use another agent within the same class. Now, it's important to know that although within the same class, there are several different criteria or factors that we want to consider that make them essentially different or essentially the same as well. Haloperidol and droperidol, we know that they essentially have a multifactorial mechanism which makes them attractive or wanting to be used in the specific disease state of abdominal pain, given that they are dopamine antagonists, alpha antagonists, and do have serotonin and histamine blockade, which then owe its anxiolytic properties, antiemetic properties, as well as decreased perception of pain, which then we could see, and of course then it makes sense that it would essentially relate to a potential opioid use reduction. And then as far as practice in the emergency department setting specifically, there is differences within its onset and shorter and half-life, in which droperidol has a faster onset and shorter half-life. So essentially, whenever we want to have abdominal pain be treated fast, droperidol may be something based on its pharmacokinetics, in which we want to utilize it over haloperidol. And then a shorter half-life, essentially, that was more attractive in comparison to haloperidol, as we do not want the sedative effects to last very much longer or put them at risk of their adverse effects for much longer as well. So overall, the study aim, given the background that was previously described, is to really evaluate whether the use of droperidol specifically for undifferentiated abdominal pain in the ED reduces the amount of morphine milligram equivalents administered within each patient encounter. Now, as far as study design, I found it quite unique in that the DREAMER study essentially was performed from the year and month of January 2022 to February 2024. And overall, it was the same patient, so as depicted by patient A, but 2 different encounters within the duration of 18 months. And essentially, each patient had a self-matched encounter, in which one encounter they received only droperidol and an opioid, which is called the droperidol encounter, and then the non-droperidol encounter, which is where they received no droperidol but did receive an opioid. And that was the schema of the study and study design. And then further going into it in its analysis, it was retrospective in nature, an observational single-center study. And as I depicted before, it had that self-matched patient encounter, which they had a total of 50 patients, each one having an encounter where they received only droperidol, and another encounter in which they received droperidol and an opioid. As far as pertinent or all of the inclusion criteria within the study is essentially they looked at the adult population years of 18 to 88. They had to have abdominal pain listed in their review of systems. And then as far as diagnosis, it was primarily undifferentiated abdominal pain, but could include those that were related to cannabinoid hyperemesis syndrome, cyclic vomiting, acid reflux disease, and peptic ulcer disease. And then exclusion criteria were those that essentially underwent surgery within 24 hours of their hospital admission, received haloperidol, or received droperidol for agitation or sedation. So essentially any other indication other than pain or antiemetic use. When looking at outcomes, their primary outcome was then looking at the difference in MME administered between the 2 groups. And then secondary outcomes were to include the need for rescue analgesic administration or need for rescue antiemetic administration. They also looked at things such as rate of hospital admission, the hospital length of stay, and then any adverse effects that may be attributed to droperidol, such as arrhythmias, extrapyramidal symptoms, as well as allergic reaction. And I think it's really important to go ahead then and define need for rescue analgesic administration or antiemetic administration, in which it was any agent to each respective class given at least 30 minutes after droperidol for the first after the droperidol for the first opioid administration. Now, as we get into results and looking at the baseline characteristics, they were essentially within that population of the total patients of being 50, a number of 50, and then their age was around their late 30s. There was essentially a female predominance, and of course, droperidol was given through the intravenous route in 100% of the population. Now, looking at the doses, essentially those did differ, in which the patients could receive 1.25 milligrams, 2.5 milligrams, as well as 5 milligrams, with majority of the patients receiving 2.5 milligrams at 68% of the population, and then 16% for the 1.25 milligrams, as well as the 5 milligrams within that population. And because guidelines essentially recommend a multimodal approach, as well as looking at opioid administration, it's important to look at concomitant medications given within this patient encounter or each patient encounter, in which we see that any opioid between the droperidol and non-droperidol group was statistically significant, with 62% receiving any opioid in the droperidol group and 100% receiving those in the non-droperidol group. Now, as far as any antiemetic given, we see that although not statistically significant, there was a difference in droperidol use around a droperidol group, around 84% receiving antiemetic versus 96%. Tylenol, low use, but essentially a use of around 4% in the droperidol group and 2% in the non-droperidol group. and then ketorolac is 16% versus 14% in the non-droperidol group. And as far as results in the DREAMER study, essentially for that primary outcome, they did see an overall decrease in the total MME administration or being administered, in which the droperidol group received around 10 less versus the non-droperidol group at 19.4, which did reach statistical significance for a p-value of less than 0.05. Now, as far as secondary outcomes, there was none that reached statistical significance, but there was essentially a numerical benefit within the droperidol group as it relates to rescue analgesic and rescue antiemetic, in which we see that 34% in the droperidol group received that analgesic compared to 50%, and then antiemetic 24% versus the 36% in the droperidol group. There was essentially no difference or similar outcomes as it relates to hospital admission between each group, 28 versus 24%, and then hospital length of stay as well, which was 2 to 4.75 versus 1.75 to 3 for an interquartile range, or 3 versus 2. And then as adverse effects were essentially looked at, we saw that there was actually no adverse effects reported in the droperidol group, but was actually one in the non-droperidol group, which is essentially an allergic reaction in which they were unsure of the offending agent. And in conclusion, their author's conclusion was essentially that droperidol administration did result in a significant reduction in MME administration. Now, looking at this for forward discussion and as well as a critique within the DREAMER study, I feel like there were a few strengths, in which the first one being study design. I think it was very unique in one of the very first studies in which they had a self-patient match encounter, which I feel could mitigate bias as well as differences in perception of pain between different patients. I also looked at focused outcome being a strength of the study, and that we looked at specifically MME reduction, as briefly explained in the background that this is important, although we don't know essentially to what degree short-term opioid use in the EDs could relate to dependence, but essentially knowing that it is important to mitigate its use, that was a good outcome to essentially look at. And then as far as generalizability, I think looking at undifferentiated abdominal pain in the ED and knowing that the workup essentially will not reveal an exact cause, or more times than not, essentially a lot of patients do just leave the ED with a diagnosis of undifferentiated abdominal pain. I feel we got a really good patient population from that standpoint. And then as far as secondary outcomes, I thought of those as important as well, just because we know that a multimodal approach is important. So essentially looking at antiemetic use, other analgesic use is important to also consider when treating these patients for abdominal pain. Then as far as limitations go, I feel like one of the first key points to touch on is essentially pain scores. And I overall think it is important that we saw that reduction with total MME administration within the sole droperidol group. But I was curious to know, or I think it's important to understand, if essentially total MME reduction would equate to a difference in pain scores and to what degree. Then secondarily, there is, I believe, to be a limited external validity, not from a patient population standpoint, but possibly a prescribing practice standpoint, in which different emergency departments can use a multimodal approach fairly differently. As in the study, we saw low use of agents such as Tylenol and ketorolac, where it may differ in your own practice, where you may see more use of. And then dose variability was also a limitation in which I thought about, in which it would be important to essentially look at or know if there is a dose-dependent effect as it relates to MME reduction with droperidol, as we can see that most of the patients got 2.5 milligrams, but would be curious if there would be a dose-dependent effect based if we give higher versus lower doses. And then lastly, although it was a strength in the study design in which we used that self-matched patient encounter, I think there could be a limitation in that these patients could be variable as it relates to time between encounters, from a standpoint of them essentially having different comorbid conditions or different diagnoses between the two encounters, which may relate to essentially what their benefit was between each encounter seen. Now, as far as my own conclusion, or the biggest takeaway that I have from this study, is understanding that droperidol may be an effective opioid-sparing option for abdominal pain in the emergency department, and essentially could potentially reduce opioid-related risk while maintaining, of course, effective symptom control. And that is all I had. I will open it up to any questions from the group.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.